Hi there. Welcome back. And we are here with Dr. Damato. Welcome to your first track of day one. And let's get started. So, today we're going to hear about how Dr. Damato's patients made him a better ocular oncologist. And so, Dr. Bertil Damato is an ocular oncologist currently practicing as a senior clinical research fellow at the University of Oxford and attending eye surgeon at Moorfields and Oxford eye hospitals in the UK. After his remarks, of course, we'll have a short Q&A before taking a break and head into the next session. But let's give a warm welcome to Dr. Bertil Damato. Welcome.
Hello, good morning. Thank you very much for inviting me. I'm delighted to be speaking to you today. I thought you would like to hear about how my patients have made me a better oncologist. Because what I think I'm going to say will apply to all ocular oncologists around the world. So I'm going to speak about consent for the use of data, tissues, and images for research, audit, and teaching, donations, and patients helping themselves and others. So I'm going to start by going back to this landmark paper by a German group in 1996 when they reported that patients with uveal melanoma develop metastatic disease only if their tumor shows monosomy 3, chromosome 3 loss. So as soon as I saw that paper, I went to my hospital. I said, look, what has just happened here? We've got to do something about this. If our patients ever find out that we're only treating their eye and not doing anything for their survival, they will never forgive us. And to my amazement, the hospital paid for a postdoctoral research fellow to change this research finding into routine clinical practice. And thankfully, patients had been giving us consent for the use of the data and their tissues for research, and we were able to replicate the German results. And thanks to this, we were able to start doing genetic typing for patients as a routine clinical service in 1999. And as far as I know, we were the first to do so in providing a routine clinical service. And thanks to the tissues and data from patients, we're able to do further studies to find that prognostication is improved if we don't just look at tumor size or tumor histology, or tumor genetics, but to look at all of these things at the same time. And we kept working on that. And years later, with data from more than 4,000 of our patients in Liverpool, we were able to develop LUMPO, the Liverpool Uveal Melanoma Prognosticator Online. And this estimates the survival probability according to clinical features like size, location, and so on, histology, and genetic findings, also taking into account normal life expectancy according to the age and the sex of the patient. And this has turned out to be a great success. And then this, at first we were relying on FISH, with fluorescence in situ hybridization, which only looked at one or two areas on chromosome 3, not very sensitive. But then this new technique came out, multiplex ligation dependent probe amplification, MLPA, and we introduced this into our country, our hospital for uveal melanoma, and it produced lots of numbers, and we didn't know what the numbers meant, and I analyzed the numbers, and we were able to learn how to understand the data produced by this genetic test. I'm really delighted that this is now being used commercially by Impact Genetics, and And we're not getting the royalties, but we never expected that. We don't need that. It's great to see that our research, thanks to the help from patients, is now helping others. And then when I moved to San Francisco in 2013, one of the first things I did was to approach Boris Bastian, who had developed a test, next generation sequencing, looking at 500 different mutations. And we got a grant from That Man May See, now called That All May See, with funds from patients. And we were able to do this test on about 50 uveal melanomas. And we found that it worked extremely well, gave us lots and lots of information. And now this is being used routinely in San Francisco and is starting to be used in other places as well. So next is audit, when we do quality evaluation. So in Britain, our oncology service is funded by the National Health Service, which is always short of cash, as indeed many other health services are. And we wanted to do MRI scans on all patients, but it was too expensive for us to do MRI scans on everybody. But thanks to the prognostication methods that we developed, we were able to identify high risk patients. And because we're doing this expensive test on selected patients, we were able to get a very high yield. And so it became affordable to the health service. So patients gained a lot from that. And there were very few patients who we did not include who developed metastatic disease. So that's another success story. And we've also done quality evaluation with patient data on plaque radiotherapy using ruthenium plaques, which deliver beta radiation that's a short range. It's different from the iodine plaques used in the United States. It's a ruthenium plaque. And we were placing the plaque eccentrically. So it looks as if you've just missed a bit of the tumor, but in actual fact, the tumoricidal effects of the radiation extend beyond the visible scar. And we found from the middle graph down below, extremely good local tumor control rates with good conservation of vision, of course, unless the tumor was touching the optic nerve or fovea. So these studies enabled us to continue to treat the tumors without a very wide safety margin with very good results. And with proton beam radiotherapy in Liverpool, we also audited our results, and we found that there was loss of vision even when the tumor was very far from the optic nerve and from the fovea, so that these structures did not receive any radiation. There was something else causing loss of vision. And that added to some evidence, support for my hypothesis that what's causing loss of vision in these patients is the toxic tumor syndrome. It's what I called the toxic tumor syndrome, which has now become widely accepted as a concept and as a term. And so what happens is that when the radiation damages the arteries and veins inside the tumor, they start to leak fluid and to starve the tumor of oxygen, so that you get hormones spreading in the eye that make new veins to cause hemorrhages, high pressure, lots of problems. And that has stimulated a whole new line of treatment that we didn't have before. Another sort of audit was performed in the United States with patients from all over the United States when I was in San Francisco under the auspices of the Ocular Melanoma Foundation. And we looked at the patient's experience with ocular melanoma, what they liked, what they didn't like, what they felt about the treatment they had received. And for me, it was very, very instructive. I really learned a lot from this study, thanks to all the questionnaires that were completed and submitted by patients and their spouses and so on. And this resulted in us developing a Bill of Rights for patients. that they need to be given proper information, time to decide what to do, the chance to ask questions, to be allowed to have relatives with them, to be informed about all the therapeutic choices and the biopsy, and to have emotional support, psychological support, all these things. And I think that this should really be obligatory reading for all trainees in ocular oncology, so that everyone can understand what matters most to patients when they're receiving care from us. And I've also been helped enormously by 1,500 patients back in England who completed up to 9 questionnaires over about 20 years, which educated me and my colleagues and anyone who reads these papers about quality of life after removal of the eye as compared to radiotherapy. And we found that really there wasn't much difference in quality of life between radiotherapy and removal of the eye, surprisingly. But that's what we found, that once the initial shock passes, patients have a really good capacity to recover. And so they regain a good quality of life once they get used to things. And there's a graph showing that. And there were very few patients, maybe 1 in 5 patients, reported that they had a poor quality of life after treatment for uveal melanoma. And then when we investigated why, this was mostly because of causes unrelated to their uveal melanoma. It was because of poor social support, if they were living alone or bereaved, or if they were unemployed and had financial difficulties, or if they had poor general health because of arthritis or other diseases and so on. And this helped us to treat patients not just from the point of view of treating their tumor, but to treat them holistically and to include their family as well in the care that we provided. So it's really improved our practice a lot. And thanks to the consent from patients to use their images in teaching, we've been able to publish textbooks with pictures, anonymized pictures. Nobody can recognize who the picture's from, and so on. We've been able to publish lots of textbooks. And I also had an online atlas of ocular oncology, and now it's coming out as a textbook of ocular oncology with a clinical atlas of ocular oncology, and that's due to be published in the next few months. And the main difference between my atlas and other atlases is that the tumors and the lesions are organized according to their color and their location in the eye, so that practitioners can diagnose conditions that they may never even have heard of. Whereas with conventional atlases, the various diseases are organized according to the pathology, according to diagnosis. And so you can't open the page you need unless you know the diagnosis, and you don't know the diagnosis unless you find the page you need, whereas my atlas overcomes that. And so hopefully it will help improve diagnosis elsewhere and everywhere. Another here you can see how valuable pictures are, the pictures that patients let us use. There's a big problem in distinguishing moles at the back of the eye from melanomas, from small melanomas. And therefore, after thinking long and hard about it, I developed the acronym MOLES, which stands for mushroom shape, orange pigment, large size, enlargement, and subretinal fluid. And I developed a scoring system which has been validated at Moorfields Eye Hospital in London. And this enables non-experts to distinguish between benign moles and malignant melanomas and to estimate the likelihood of malignancy in these tumors. Now, there have been other systems, such as the TFSOM system developed by the Shields, which is very good and very successful. But that relies on ultrasonography to measure echoes within the tumor, whereas this system does not require ultrasonography, which is important because many practitioners, many optometrists just don't have access to ultrasonography. And also, images from patients are invaluable in giving lectures, in teaching, and all ocular oncologists are in great demand to teach general ophthalmologists, optometrists, and so on about ocular tumors. Funds. We've really been helped a lot by donations from patients. In Liverpool, what I did was I didn't ask them patients for any money because I didn't want them to feel obligated or embarrassed or anything like that until they stopped seeing us, until they didn't need to see us anymore. And then in a discharge letter, there was a little note that just as they have benefited from donations from previous patients, if they want to make a donation, that would be very welcome. And so patients used to run marathons, organize coffee mornings, and things like that. And that enabled us to get equipment that would have been unaffordable for our hospital, such as ultrasound equipment, equipment for us to do our genetic studies in-house instead of relying on others, and of course, research. So this has been very, very precious and really helped us to do our work much better, to provide better care. And in San Francisco, I was really impressed by the altruism that I witnessed there. Patients donating large sums of money, which go into the millions of dollars, which have enabled us at UCSF to build a new eye department. And we also used to get sponsorship for research, and that is the funding that enabled us to do our studies on next generation sequencing for uveal melanoma. It's all from patient donations. So patients help me do better when they help themselves, when you help yourselves if you're patients. And the best way to help yourself is to prepare for consultations, to learn as much as you can, hopefully from a reliable source. In Liverpool, I had prepared a 75-page guide for patients, which we used to mail to patients before they came to us. So they knew a little bit about different ocular tumors, the various investigations, what to expect when they arrived at the hospital, about the different treatments, and so on. And that really helped communication during our consultations. And the other thing that we did to improve communication was to give patients audio recordings of the actual consultations. And first it was with audio cassettes, and then many years ago when those went out of fashion or when they became unavailable, then on CDs. And then in San Francisco, I had a hospital iPad, and I was able to record the conversation on the iPad, and my secretary was able to email the recording to the patient using a very special, secure way of doing so. Then patients help themselves by asking questions, preparing questions before the clinic visit, keeping informed afterwards, keeping a portfolio of all the reports that they receive, of what they were told, all these things, getting help from us, from the family, from friends, from other patients, from patient advocacy groups like Ocular Insight, and so on, by doing all they can to keep fit and to keep smiling. I know at times it's very difficult to smile, but we tend to feel better when we smile. Strangely enough, even if we pretend to smile, it makes us feel better. There's some sort of reflex. And it makes the people around us feel better, even the people who are looking after you in the hospital. A few weeks ago, I was an emergency admission myself, and I kept smiling to everyone, and they smiled back. And then there was a porter wheeling me on a trolley to to have my chest X-ray, and I smiled and made conversation. It turned out that he came from Kerala, and I had been to Kerala on holiday, on vacation, and he lived just a few kilometers from the hotel I stayed at, and so I had a very nice conversation about the cuisine in Kerala. And it was around midnight, and it cheered him up after a long, busy day, probably. It cheered me up. And so that kind of activity really raises spirits, and it's something that's really, really important and perhaps not emphasized enough. And one way patients help themselves, one way you can help yourself as a patient, is to be grateful. And when I was in San Francisco, I arranged for Jamie Cohen, a health psychologist at UCSF, to provide psychological support to patients. And one of the things she taught them was to appreciate their assets, to be grateful for what they have. And that really made patients feel much better. And I myself have learned from patients who told me months or even many years after treatment, they said, "Oh, that melanoma was terrible when it happened, but now, years later, I can see that it was a blessing in disguise, because now I'm so grateful for what I have. I really appreciate what's important, and I stop bothering about what's not important. And my life is so much better than I've got so much more insight than if I had never had that melanoma." So it's important also to help other patients, because it's not just gratitude that's therapeutic, but altruism is also very, very therapeutic to those who practice it. So by supporting ACEs and other patient advocacy groups, by giving feedback to hospitals, writing thank you letters, for instance, that really raises the morale of the nurses and of all the people who are there and working under difficult circumstances quite often, by filling in questionnaires if you receive any, by helping the hospital to prepare information sheets for patients, and by reviewing grant applications. It's really very valuable when patients participate in the process and let us know what they consider to be important in research and so on. By participating in trials and in registries, and I'm going to speak about that very soon. By becoming a buddy, so once you've been through the whole process, you become an expert, and so you can help newcomers, patients who've just been diagnosed, and you can point them in the right direction, share your experience, and so on. And yes, by smiling more, make everybody feel much better. So, in conclusion, I and ocular oncologists all around the world and patients, all of us, we would not be where we are today without all the wonderful support and kindness that we have received from patients, and we continue to receive from patients. And that's one of the messages that I share with when I'm teaching students and trainees, how wonderful this experience it is. It's a great privilege to help patients at difficult times for them, and to be there. And it's really great to develop these relationships with patients, to work together. And I'm really grateful for all the support and the kindness that I've received over the 40 years. And I'd also like to acknowledge my colleagues, past and present, from different hospitals I've been fortunate to work at. Thank you very much.
Thank you, Dr. Damato. What a fantastic presentation. We're glad to have you here, and I want to go ahead. We are going to take some questions in the chat, and we'll go ahead and get started with that. Is it okay with you?
Yes.
Wonderful. So let's go through the questions here. Let's see. We have a Brittany Marie. So Brittany says, I want to learn as much as I can. It's her first time on here. She was just diagnosed with a 19 milliliter tumor in her right eye, and she's going ahead with the removal. Is there anything that she should do or know?
So, if I understand correctly, she has a melanoma and is going to need to have her eye removed. Is that right?
Let's see. It says 9 milliliter, a 9 ml tumor in her right eye. So she is going to go ahead with the removal, correct?
Right. Well, what I've learned from patients is that this is a very frightening time, but patients are pleasantly surprised afterwards. The very vast majority are pleasantly surprised at how normal life is afterwards, and how how their friends and relatives continue to see them as the persons they are and not to be influenced by how many eyes they have, if they can tell the difference. And so that's really important to appreciate. The next thing is that we always advise patients to look after the good eye, to be careful what they do. If you're doing any gardening, to have tennis balls on top of each stake so you don't poke your eye. If you're walking
Mm,
through a forest, to stay well back because the branches tend to swing back if you're behind somebody else. Things like that. And then to wear glasses with toughened glass in case you're walking along the sidewalk and a bit of grit flies into your eye or something. Another important thing is that the other eye doesn't work any harder just because it's the only eye that's seeing. So you can continue reading, watching TV, doing anything you want because our eyes work full steam ahead, day and night. There's no volume switch, just a shutter. So
mm,
you can continue doing what you want. And the third thing is that some patients develop phantom vision, phantom eyes for a few weeks after the eye removal, and they might see colors out of the eye that's been removed, or shapes, or I might even think they see people, and get worried that they're going crazy or something like that. But that's a perfectly harmless, normal phenomenon that is not very rare. So it might happen. So don't worry about it if it happens.
Thank you so much for sharing. And thank you, Brittany, for sharing your question. And Rob Spence is asking, is it possible to get any of these documents that Dr. D'Amato is referencing? And I know there's some interest in the 75-page new diagnosis doc that comes from Rob Spence. Is there somewhere that we can find that?
Um, I'll I'll send a copy to Melody
Okay.
at a current site.
Great. And what we can do is we can put that into Dr. D'Amato's speaker documents. So if you go to his speaker profile in the app, we'll make sure that you can find it there. So give us a couple of days to do that, Rob, and we'll get that for you. And I am, let's see if we have any other questions here. We have, do you offer additional biopsy or aspiration or pathology, aliquot, to all newly diagnosed OM patients for deep genomic workup? Why or why not? From Kevin O'Neill.
Yeah. In Liverpool and San Francisco, I was very lucky to have retinal surgeons working in the oncology team, such as Dr. Afshar at UCSF, and they were able to successfully biopsy very small tumors, less than 1 millimeter thick, to do genetic testing for prognostication. But for that to be successful, you need to have an expert surgeon and an expert laboratory team. And not all eye departments are fortunate enough to have those wonderful resources. So you can get biopsies in some hospitals and not in others.
Hmm. Okay, well, thank you for that information, and Kevin, thank you for your question. If we have, do you have any other things? We don't have any other questions at this time, but do you have anything else you'd like to share for the OMIs that are watching today, or anything about the community?
Um, uh, so, really, what I've tried to get across in my talk is that kindness is a two-way process.
Mm,
And just as nurses and doctors and hospital staff are kind to patients. Patients are kind to the hospital staff and to the people caring for them. And that's very, very uplifting. And it really improves the care that is provided and received because people tend to become more enthusiastic, it becomes a happier place to be, and so on. And what I have seen is that when we have this wonderful interaction with patients and the staff are uplifted and so on, then we, we tend to attract the best, the brightest, and the best from other parts of the hospital because they see that we're a happy unit, that we're an efficient unit, that our patients are happy, and so they want to come and work for us in ocular oncology. And I've seen that in more than one place. So just by, I know it's difficult at times to be to be sort of cheerful and so on, but that's enormously important, really, really important, and I've seen it improve care a great deal.
And so what I'm really hearing from you is that to try and practice empathy for all those that are in your sphere of influence and trying to help you through this diagnosis. And we have a couple more questions for you, Dr. D'Amato, that come in just recently. What do you suggest if you're not feeling understood by your patient?
Uh, well, first of all, patients can do no wrong, especially at a difficult moment.
Mm,
So if you're not understood by the physician, then try again. Try and rephrase the question or the problem. Uh, and then, if that doesn't work, then perhaps you can speak to a nurse. Quite a lot of patients are afraid of, don't like to take up the time of a busy physician.
mm,
Like I always ask patients if they've got any questions, and then I leave a pause for them to have time to ask a question and so on. And then patients say they're fine. And then when they go back out and they go into the next room to speak to the nurse, they have dozens of questions for the nurse.
That seems common, I would think.
So, so it's really important to ask the questions, to explain yourself, and then to try and understand. If the doctor's not understanding you, the physician's not understanding you, to try and understand why. That's one thing speaking to an experienced ocular oncologist who quite often knows what the patient's going to say by the first word of the sentence and feels comfortable tackling difficult points and is confident about doing so in a sympathetic manner. But for optometrists and ophthalmologists who come across a patient with an eye tumor once a year or once every 5 years, it can be quite upsetting for the physician to to tackle the subject and to speak about difficult things. It can be really
Right.
upsetting for them, difficult for them, and that is why it's great that we have these ocular oncology services where you have somebody who understands patients and who can relate to patients in this way. But if you're not happy for one reason or another, then I would try and get a second opinion from somebody else. Some patients are worried about asking for a second opinion. They don't want to embarrass the physician, perhaps. But I've always said that second opinions are win-win situations.
Mm,
If if you have a different opinion and it's better than the patient's gained, if the other person agrees with what you've said, then that's good too. So second opinions would be a good thing to do in those circumstances, I think.
Thank you so much for that advice. I think that there's a lot here for people to take away from. And I would almost even suggest if you miss the questions with the doctor and you ask them for the nurse and maybe she can't answer them right away, write them down. I know that I have a friend who has a diagnosis of something entirely different, but keeping a notebook of all the questions you have was helpful for her. And then we have another question regarding your staff. It'd be kind of nice. Can you share an anecdote about learning and being inspired by your staff?
Um, uh, by staff. Yes, yes, I've been really, really fortunate in having very dedicated staff who I felt very comfortable with. I was able to trust them. To That brings me to another point, which I'll mention in a moment. To encourage them and to see them encouraging others around them. That's really special. Um, so inspired by staff, yeah, that's what I can say. The other thing I can say is that we used to have, after every new patient clinic on a Monday in Liverpool, we used to have a team meeting to discuss all the patients and what should happen and so on. And we had a full-time health psychologist as part of our ocular oncology team just for our patients. And every week she used to have to give an anecdote, a story about a patient she had spoken to the previous week. And she taught us all so much that we couldn't have imagined otherwise. She really helped us understand how there's so much going on behind the scenes in a patient life that we wouldn't have thought of otherwise. There are things that patients don't mention to us, things that are going on in the home, problems and difficulties, recent bereavements, recent illnesses in the family, and so on, that have an effect at the time they are diagnosed with their tumor. And so we learned a lot from having a psychologist speak to us each week, and that was very inspirational too.
That's really precious, and I appreciate you sharing that with us. And I've got a couple other questions here. So we do have about 13 more minutes before, and we ended the presentation a little early, so we do have more time for questions. That's why we have the availability to ask a few more. So thank you for sharing that time with us. I have one from Margaret Southerly. She says, "I wasn't able to get a biopsy due to location. Is there a liquid biopsy that can tell if it's class 1 or class 2?"
I think those biopsies are coming.
Okay.
There's a lot of work being done on that. And any day now, I hope that we do have liquid biopsies available to us. Um, the thing about these liquid biopsies is that they have to be accurate. We don't want to give patients the wrong information, the wrong advice. So even when one is developed, it needs to be tried and tested over some time before we can use it in the heat of battle, so to speak. But when I was in San Francisco, there was a patient of mine who was being treated by the physicians for lung cancer, and the treatment wasn't working too well. The systemic chemotherapy that she was receiving wasn't too successful. But they were able to do a liquid biopsy, do a blood test, and to find the mutations in the tumor from that blood test. And thanks to the results, they were able to change the chemotherapy they were giving.
Hmm.
So, yes, it is happening, but in some tumors, it's happening more quickly than others.
Hmm. Thank you for sharing that, and thank you for your question for sending that in, Margaret. If you have any other questions, be sure to reach out. And I have one last one here, and the question is: you mentioned support, and so how can family and friends be supportive when someone receives a diagnosis?
Um, every individual is different,
Right.
and every person with ocular melanoma has different needs, different expectations, and so on. But there's nobody better than family and friends to understand that person. And I think what's really important is to be there and to ask, how can I help? Uh, the other thing that one can do if you've got somebody close to you who has a serious illness, not just ocular melanoma, but any other serious illness, is to try and find a reliable source of guidance as to how to speak, how to help somebody close to you who has a serious illness.
Great
Because
advice.
there are lots of do's and don'ts, and 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 so there's a learning process which can be shortened by educating yourself from a reliable source. And it works both ways. Just as the friends and relatives need to learn how to help someone with ocular melanoma, patients with ocular melanoma also need to learn how to speak to their family, their children, their colleagues at work, and so on. And that was one of the criticisms from the Ocular Melanoma Foundation survey. Quite a few patients said that they wish that their hospital, their physician, and the nurses, and so on, had given them some advice on how to relate to friends, relatives, how to speak to them, and so on, because they found that very difficult.
And thank you for sharing that. I know that that's a really long process for people too. I had a very dear friend who had cystic fibrosis, and I think one of the best takeaways I learned from that process with them is even when they're in the hospital, when family or friends are in the hospital with a very severe diagnosis, sometimes it's helpful to not ask questions because they're answering questions from other family and friends all day long. And sometimes it's good just to be there to talk about anything other than what they're going through, just to be helpful on a friend and family level. And I wanted to share a comment from someone that is in the chat here. Chantal Feinberg is bravo for having a psychologist on your team, and she's maintained for years. Every cancer team has maintained one for years, and that every cancer team should include an active psychologist or social worker. So she commends you for doing that.
Okay.
Absolutely. So I want to go ahead and wrap up today. What a fantastic presentation. If you loved what you heard from Dr. Bertil Damato, know that he is going to be in the next session, which is going to start at 11 a.m. So we'll see you in just a few minutes, Dr. Damato. But thank you for this presentation.